Although mind-body connection concepts are older than Descartes, it was George Engel's work that helped encourage almost all of us to replace the medical model with a biopsychosocial one. The biopsychosocial model, as you know, has gradually become the global gold standard for sex therapy and sexual medicine. The model has clear utility and it's easily pronounced. However, given its importance as the current gold standard in our field, it's incumbent for each of us to periodically re-examine how we apply it and why. Because we all need to make sure we're applying the model in a manner that optimizes its strengths and minimizes its limitations. Most sex therapy practitioners and sexual medicine physicians pay lip service to using the model for diagnosis and treatment. However, it's my observation after 50 years in this field that each group tends to focus on one or perhaps two aspects of the model overly exclusively, with insufficient awareness or attention to other contributing factors. Now, examining one's approach will remind us of criteria that we are using productively already, but it will also alert us to blind spots resulting from specialized training cultivated within our professions of origin. During much of the 20th century, psychosocial factors were given great prominence, first by psychoanalysts and later by sex therapists who typically were mental health professionals. It seems to me that too many mental health professionals still fail to sufficiently attend to the biomedical aspects of a patient's complaint, both in terms of understanding etiology and in planning treatment. That's despite a stated allegiance to a biopsychosocial model. It's not just the therapists, of course, who are biased at times, as most physicians do not truly attend to the cognitive, emotional, behavioral, and cultural factors contributing or exacerbating a sexual disorder. Few physicians, when prescribing medications to improve sexual function, inquire of the patient or of their partners if the patient's goals for sexual activity are aligned with those of their partner. Even for those physicians who might prefer in-depth assessment, the time limitations of most physician and even specialist office visits typically negate the potential for multi-layered engagement. A setback for the biopsychosocial model was the Viagra launch with its emphasis on medicalization. The corresponding impact of Viagra catalyzed the ascendancy of urology as quote-unquote sexual medicine experts over the other specialties which had traditionally managed sexual issues. To give you a first-hand account, Pfizer recruited me to join a panel of 3 urologists to launch Viagra at the 1998 AUA annual meeting. Now, each urologist got 10 minutes to describe their Viagra clinical trials. I was only given 2 minutes to give, quote-unquote, the psychological balance to the medical equation. Now, memorably, at least to me, the head of urology at New York Montefiore Hospital yells out from the back of the room, "Michael, sex therapists will go the way of the dinosaurs." Now, of course, the audience laughs, but fortunately, to paraphrase Mark Twain, that announcement turned out to be premature. Sexual medicine's initial leaning towards the medical model was now reinforced by the medicalization inherent in pharma's marketing of PDE5 inhibitors. However, gradually things were rebalanced as sexual medicine progressively adopted a biopsychosocial perspective during the early 21st century, facilitated by the emergence of reformed and newly multidisciplinary societies. So some of them, like SSI, became SMSNA, ISSR became ISSM, and there's no doubt it was the presence and valued participation of female clinicians and researchers, as well as mental health professionals, that helped lead the charge. Now, take my word for this. I was there when it all began, and I was there when it changed again for the better. And to name a few involved, amongst others, Sandy Lieblam, Ray Rosen at Rutgers, Stan Altoff in Cleveland, Leonore Tiefer and Miriam Dunn in New York, Daniel Whitman in Michigan, and myself, who were all STAR members, made a difference. By the way, while STAR has always been multidisciplinary to its credit, STAR's membership origins as East were disproportionately male physicians, many of whom had strong biomedical biases. Now, but reciprocally as STAR, we've benefited greatly from expansion and expanding our members' diversity, including many more mental health professionals. But too often it does seem that biomedical gets overlooked, or at least underexplored. Finally, while not well studied, how many how many of us really provide fully competent cultural awareness and sensitivity when evaluating and treating our patients? Telehealth and the flattening of the world allows access to patients from just across the globe. That creates an ever-increasing need for practitioner sensitivity to the different patient populations, given the implicit diversity regarding sexual practices, gender identification, and sexual orientation. The failure by many to address those preceding issues strongly suggests that despite almost all of us paying lip service to a biopsychosocial perspective, that model is not fully guiding the practice of many clinicians, regardless of their profession of origin. First, given the biopsychosocial model's importance to our field, periodically we need to re-examine how it's understood and applied. Second, to re-examine will remind us of criteria we use productively, but also alert us to blind spots that we need to be aware of. Third, the term must be viewed as a stand-in for all the predisposing, precipitating, and maintaining biological, medical, surgical, cognitive, behavioral, emotional, social, and cultural factors involved in the etiology and treatment of sexual disorders. Those factors are best understood at a granular level. You got to get the details based on their proportional contribution, because it's going to vary to the whole for a true grasp of an individual's experience. Now, despite increasing respect paid to each other by the various professions, our viewpoints do still remain too separated. The understanding and treatment of sexual disorders is best accomplished through an integrated, transdisciplinary approach that offers more than just combining techniques. One such approach can be illustrated using the sexual tipping point model.